Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'll be doing another Kahoot, and I will be going over hematology. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already, and don't forget, I'm now offering Next Generation NCLEX review sessions. I can't speak. It's a two-part session, and you can reserve your spot by going to my website, nexusnursinginstitute.com. While you're there, if you are a current nursing student, you're not studying for the boards, you're just trying to survive, you're trying to get through the program, check out the audio lessons I have available. You can check that out on my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms such as TikTok, Instagram, and Facebook. My handle's the same everywhere, Nexus Nursing, so be sure to check that out. Without any further ado, guys, let's get started. Hematology. First question. Who's more likely to develop rheumatoid arthritis? Would it be a 20-year-old woman? Would it be a 45-year-old man? Would it be a 65-year-old woman? Or would it be a 70-year-old man? Who do you think would be most likely to develop rheumatoid arthritis? What do you guys think? You guys are doing great on the live. I'm seeing all the right answers. Very good. The 65-year-old woman. So guys, when it comes to rheumatoid arthritis is an autoimmune disorder. And when you hear that word autoimmune disorder, that's just a fancy term to let you know that this patient's body is attacking their own tissues, okay? So their own immune system within their body is attacking their own tissues. Now, when it comes to rheumatoid arthritis, what's happening is the joints are what's primarily affected. So the patient can have, bone stiffness, they can have pain, they can have joint deformities from this. And who's more likely to be diagnosed or develop rheumatoid arthritis is going to be a woman. It's going to be female. Females get this almost 3 times more likely to get it than men. That's number one. And number two, we see this as the person is advancing towards the geriatric age. It usually becomes more pronounced or develops, I should say, around the 60s. So a woman in her 60s, she's the one most likely to develop it. A DMARD has been ordered for your patient. What do you expect to administer? Do you expect to administer Tylenol, methotrexate, ferrous sulfate, or prednisone? I think I spelled prednisone wrong. Prednisone. No, I spelled that right. Okay. So anyway, DMARD, I didn't want to write the whole thing out, but DMARD stands for disease modifying, DMA, disease modifying anti-rheumatic disease, disease modifying I think rheumatic. Guys on the live, am I right? Okay. Anyway, the correct answer is methotrexate. I'm almost sure the R stands for rheumatic because that's what we get it for. So what we expect to give, guys, is correct. It's methotrexate. Now, this medication is going to be great because it helps with decreasing inflammation. Now, Tylenol, that's an NSAID. Ferrous sulfate, that's iron. And prednisone, that is a steroid. Prednisone's great for decreasing inflammation as well. However, we're talking specifically about DMARD, and prednisone is not a DMARD. Prednisone is a steroid. So because we're talking about a DMARD, we're talking about methotrexate. That's what you would expect to be given. A patient received a blood transfusion due to trauma and has a potassium level of 7.2. Which medication do you expect to administer? Is it IV insulin? Is it IV potassium chloride? Is it oral spironolactone? Or is it oral lisinopril? Your patient got a blood transfusion due to trauma. They now have a potassium level of 7.2. Which medication do you expect to administer? That's right, insulin. Why? Insulin pushes potassium out of the bloodstream and into the cell, so that's how it lowers the potassium level. Remember, your potassium level is supposed to be 3.5 to 5. Let's talk about the wrong answer choices. IV potassium, 17 people chose that. If I just told you that your potassium level is supposed to be between 3.5 to 5, and guys, that is a very narrow therapeutic range. Anything outside of that 3.5 to 5 can cause the patient to have cardiac dysrhythmias. That's why we're so concerned with the level of 7.2. We have to get that down. There's no way in the west side of Wakanda, we're going to give that type of patient IV potassium chloride. We're not trying to kill them, right? IV potassium chloride is going to increase the potassium level, and we're trying to decrease it. So we're not going to do that. Next, oral spironolactone. That S in spironolactone stands for sparing or saving. It makes you hold on to potassium. We're trying to get rid of potassium, so we're definitely not going to do that. And last is oral lisinopril. Um, this is lisinopril, it ends in pril. Okay, so that's an ACE inhibitor. Here's the thing about ACE inhibitors. They actually can cause hyperkalemia. So when a patient's on ACE inhibitors, you better be watching the potassium because we don't want the potassium to get too high. This patient's potassium is already high. So the only correct answer is going to be the IV insulin because we know that the insulin is going to bring down the potassium. Which factor increases a patient's risk for developing anemia? Is it the presence of a colostomy? Would it be gastric esophageal reflux disease? Would it be a gastrectomy or would it be depression? Which factor increases a patient's risk for developing anemia? Presence of a colostomy, GERD, gastrectomy, or depression? Correct. Gastrectomy. So let's talk about this. A patient can develop most likely develops anemia when what? The RBCs are down, right? I want you to follow me. If a patient has a gastrectomy, their entire stomach, a large portion, even a smaller portion of their stomach has been removed. What is in the stomach? Intrinsic factor, right? And what do you need intrinsic factor for? Intrinsic factor helps you to absorb vitamin B12. So if a patient has gastrectomy, they can't absorb that vitamin B12. That's going to put them at risk for anemia. Someone on the live just they typed something in the comment and I want to address that. Someone on the live, sorry guys. On the last question that we just did about insulin, they said insulin and D5W and that person is absolutely correct. I want to explain to you why. If the patient's in potassium is too high and we're giving them insulin, we're going to give them insulin because we're trying to pull out that potassium. We're trying to pull it out of the bloodstream, right? To go into cell. Yes. But what do we know about insulin? It also can cause hypoglycemia. What kills you faster, hypoglycemia or hyperglycemia? Hypo will kill you much faster. So even though we're giving insulin to decrease the potassium, we have to still be careful about decreasing the patient's glucose. So at the same time, yes, we're giving them insulin, we're trying to bring down that potassium, we're watching that glucose and we're giving D5W so that patient's glucose, number one, does it draw does it decrease um too low, and number two, even though it may decrease, we don't want it decreasing too fast because let me tell you something, that sudden drop in the glucose because of the insulin can cause that patient to go into seizures. So whoever typed that on the live, thank you for bringing that to my attention so I can teach it. Appreciate it. All right, next question. A post-op female has a hemoglobin level of 11. Which symptoms would you expect to note? Would it be nothing, no abnormal symptoms? Would it be pallor? Would it be heart palpitations? Would it be shortness of breath? You have a post-op female patient with a hemoglobin of 11. What would you expect to see? No abnormal symptoms. Think about it. female patient, you expect the hemoglobin to be around, 12 to 16. If it's a male, you expect it to be around, 14 to 16. So being a female patient and it's only one off, it's 11, that's not significant enough for us to start seeing clinical manifestations, because if it's considered anemia, it's what? Mild, very mild anemia, right? We really wouldn't expect to see clinical symptoms such as pallor, such as heart palpitations, such as shortness of breath. Those symptoms we would see in what's known as severe anemia. At 11, no, absolutely not. Very good. Which is a common cause of aplastic anemia? Would it be loss of intrinsic factor? Would it be blood loss? Would it be bone marrow suppression? Or would it be inadequate intake of iron? Which is a common cause of aplastic anemia? Very good. Bone marrow suppression. Remember, guys, the bone marrow, that's where your blood cells are made. So you have your RBCs. Without that, the patient's anemic. They're going to be weak. They're going to have those clinical manifestations. And the bone marrow is responsible for making your WBCs. With that being low, patient's going to be at risk for infection. Bone marrow is responsible for making platelets. Without that, your patient's going to be at risk for bleeding. So when it comes to aplastic anemia, it's bone marrow suppression. That is the common cause. Now, look at the first choice, loss of intrinsic factor. We'd see that what? Pernicious anemia. Blood loss, that would be hypovolemic anemia. And inadequate intake of iron, that would be what? Yep, iron deficiency anemia. Which diagnosis would place the patient at highest risk for development of anemia? Would it be Crohn's disease, chronic renal failure, menorrhagia, or COPD? Which diagnosis would place the patient at highest risk for anemia? Crohn's disease, chronic renal failure, menorrhagia, or COPD? Chronic renal failure. Remember, the kidneys are responsible for making erythropoietin, which helps make the RBCs. So if the kidney's not working the way it's supposed to, it's not going to be making the erythropoietin the way it's supposed to. The erythropoietin is going to help make the RBCs the way it's supposed to, and the patient will have what? Anemia. Now let's look at the other choices. Crohn's disease. We usually don't see blood loss in Crohn's, but if we do, patients losing blood like in the stool, it's going to be very minimal. It shouldn't be enough to cause anemia. With menorrhagia, that may cause, but when you're between menorrhagia and chronic renal failure, there's not even you can't even compare the two. Chronic renal failure absolutely will place a patient at, look at this key word here. Let me circle it here. You see what this says? Highest risk for development of anemia. And then COPD. Here's the thing with COPD. COPD can cause I'm going to say it wrong. That means a lot. Polycythemia. Is that the word? I think so. Polycythemia. Yeah. So with COPD, and I'm going to explain to you why. When the patient has COPD, they're holding on to all that CO2 instead of breathing it out, right? Okay, great. So they're holding on to all that CO2, and they're not holding on to enough oxygen. So what happens is the body's going to try to compensate. The body's like, whoa, wait a minute, we don't have enough oxygen. We're going to have to do something, right? So the bone marrow ends up making more RBCs, because remember, what's in the RBCs? Hemoglobin. What does hemoglobin carry? Oxygen. So what you're going to see is a whole lot of more RBCs being produced because of the patient being in that chronic, hypoxemic state. Did I say that word right, guys? Thank you. Polycythemia. You guys know I can't speak, but you know what I'm talking about. Thank you so much. Polycythemia. That's what I'm talking about. So what happens is, because that patient's in that chronic hypoxic state, they end up making a whole bunch more RBCs to try to compensate. But when it comes to the highest risk for development of anemia, it's going to be chronic renal failure because of the decreased erythropoietin that we expect to be made because the kidneys are in trouble. Forgive me, guys. It's been a long day. All right. Eighth slide. Your patient's having an anaphylactic reaction from a blood transfusion. What should be your priority nursing intervention? Is it to give normal saline? Is it to maintain a patent airway? Is it to administer epinephrine stat or monitor vital signs? Your patient's having an anaphylactic reaction from a blood transfusion. What is going to be your priority nursing intervention? Very good. Maintain patent airway. We don't care about anything else if our patient is not breathing. So the first thing you're always going to do is make sure your patient's alive. Make sure they're breathing, right? Because nothing else matters. So number one, in that order, let me ask you guys. So I gave you the answer. The first thing you're going to do is maintain patent airway. What would you do second, third, and fourth? I'll give you a second to think about it. After you maintain patent airway, what would be your second action versus your third versus your fourth? I'll give you a second to think about it. Hannah says stop the infusion. Hannah's correct. That would have been your first thing. If that was a choice, you're always going to start whatever's harming your patient, right? You're going to stop that infusion, but that's not a choice. So the first thing you're going to do is maintain the patent airway. Next, you're going to give epinephrine immediately, okay? After you maintain that patent airway, you're going to give epinephrine. After you give that epinephrine, you're going to assess your patient. You're going to look at vital signs. One of the important things you're going to be concerned about is that blood pressure, because guess what? That blood pressure is low enough. That patient may be hypovolemic. They may be hypotensive, excuse me, and they may need normal saline. But you're going to maintain that patent airway because we need to keep them alive. Then you're going to give them that epinephrine, take those vitals very quickly, and give normal saline, give an IV infusion as ordered, as needed. What assessment findings should the nurse expect in a client with thrombocytopenia? Would it be weakness and fatigue, dizziness and vomiting, bruising and petechiae, or lightheadedness and nausea? Your patient with thrombocytopenia. Very good. Bruising and petechiae. Let's break down this word. Thrombo, clots, right? Cyto, cells, the cells that make the clots. Penia, little bit of. So that patient has a little bit of the cells that make the clots. What cells make the clots? Platelets. So patient has a little bit of platelets. Patients who have a little bit of platelets, what are they at risk for? Bleeding. There you go, bruising and petechiae. The other signs and symptoms aren't signs and symptoms of thrombocytopenia. Your patient's receiving aspirin. Which statement would require follow-up? Would it be, I will report black stools, I will take aspirin after a meal, I will drink it with my herbal tea, or I will report hearing loss? Which statement requires further follow-up in the patient receiving aspirin? Very good. I will drink my herbal tea with aspirin. First of all, any patient that's on medication, you tell them to stay away from herbs, to stay away from teas, to stay away from any over-the-counter drugs or medications. They have to clear it with the healthcare provider first. Okay, so that patient taking aspirin with their herbal tea, something like, and I'm gonna pronounce it wrong because I'm ginkgo, however you pronounce it, it's a type of tea. But I'll tell you what, guess what? It causes increased bleeding. You think that's something good for the patient to take with aspirin? Absolutely not. Where we're already concerned with the possibility of bleeding. So whenever you see a test question asking you what requires follow-up, which one requires clarification, which one requires further teaching, what the question's really asking you is which one's the wrong answer choice. And this is the wrong answer choice. Everything else is correct. That patient's taking aspirin. They absolutely do need to report black stools because maybe there's occult blood. Maybe they're bleeding in the stool. They absolutely should take that aspirin after a meal because what do we know about aspirin? What do we know about NSAIDs? They're very hard on the stomach. It can cause ulcers. So we don't want to give it on an empty stomach. And last, I will report hearing loss absolutely because it can cause what? Tinnitus. It could cause hearing loss. It could cause ringing in the ear. So we're going to teach the patient to report any of those types of symptoms. Last question. Your patient's diagnosed with lupus. Which medication do you expect to be ordered? Would it be morphine? Would it be ketoconazole? Would it be hydrochloroquine? Or would it be dimenhydrinate? What do you guys think? Very good. Hydrochloroquine. This is a medication we give. First of all, let's talk about lupus. Lupus is another autoimmune disorder where the patient's own immune system, I mean, the call is coming from within, right? The patient's own immune system is attacking their own tissues. And when it comes to lupus, every single organ that you can think of in that body is affected. So you have massive inflammation, massive attack of the tissues in this patient's body. And so you expect for that patient to get something like hydrochloroquine, which will help suppress all of that inflammation. Morphine, that is an opioid analgesic we give for pain. Ketoconazole, that's an antifungal agent. And dimenhydrinate, that is what's the name of that class of medication that stops you from vomiting? Guys, what's that class? Anti something. Antiemetic, thank you. It's an antiemetic agent. So the drug you'd expect to be ordered for lupus is the hydrochloroquine. Like I said, guys, this is going to be part one of a multi-part series because there are so many disorders in hematology that I need to cover with you guys. However, I made this a very short Kahoot because to be honest, I'm just exhausted. I'm exhausted, but I didn't want to go to bed without making this Kahoot with you guys. So I did that, but I promise the next Kahoot will be more in depth. And like I said, it's going to be a multi-part series. So thank you so much for watching with me. Let's see how well you guys did.